Namaskar. You are watching Dr. KK Med Talks Fridays with Dr. Anita Kant non-stop show 856 episode. Let's have the headlines of the day. WHO's new report revealed a startling statistics that 17.5% of adults worldwide, which means 1 in 6 individuals, experience infertility. In India, more than 30% of couples face infertility issues attributable to lifestyle preferences. According to recent market survey, due to increased awareness, the demand for fertility treatment is on the constant rise and the industry is expected to grow at a rate of 15 to 17% annually. Despite advancements in fertility treatments, there are still some unmet needs, cost and accessibility being the chief contributory factor. Recently, however, Kama Hospital Mumbai has declared to be the first straight-run hospital providing free infertility treatment. Now let's go to the topic of the day. So, when do we investigate infertility? This is the topic that we will be talking about today. And to tell us about this is Dr. PM Gopinath is here. He's very exquisitely accomplished Dr. PM Gopinath, Director and Senior Consultant at the Institute of OB and IVF, SRM Institute for Medical Sciences, Chennai. He's renowned for his expertise in obstetrics and gynecology, high risk pregnancy, infertility, and also advanced reproductive technologies. He's a luminary in the field of infertility and he's the president of Fertility Preservation Society of India and has affiliation with numerous esteemed organizations such as SOVSI, FSI, ISHRE, ISAR, ASRM, and many more. He is a highly acclaimed medical expert working at the forefront to provide quality healthcare services to his patients to help them fulfill their dream of having a baby and a family. His dedication and passion have earned him the admiration of many, lauding him several accolades. Recently, he has been graciously bestowed with the prestigious IMA Lifetime Achievement Award in 2022, a grand recognition of his excellence, humoring his unparalleled and unremarkable contributions to the medical arena, adding another feather to his already impressive list of accomplishments. So, I'm so glad to be interacting with you, Dr. Gopinath. Uh, Thank you for being with us. So we can talk about infertility today. Namaskar, Doctor.
Good evening. Good evening. Thank you for
Good
the
evening.
kind words of introduction. I think we can go on.
Okay. So when should a couple seek infertility treatment?
See, first of all, we have to understand a man and a woman, when they are everything is normal in them, when they try to plan a pregnancy, they take about 5.1 menstrual cycles to conceive. So that means on a given month, the chances of conception is only 20%. So if you take the cumulative, at the end of 1 year, 95% of them will conceive. So this not only the time frame is not for the normal and it is not a yardstick for everyone. It depends upon the lady's age. For example, if she is 35 and if you are going to ask her to wait for 1 year and come back, it's going to be too late to catch the bus. So if she is 25, then we can just wait. So that is the most important message first. The second is the investigations is what we believe by doing a invasive investigations like laparoscopy and other procedures is where you have to wait for that 1 year. As soon as the patient comes, trying to do a semen analysis is absolutely normal. You don't have to wait for 1 year to declare him saying that he's abnormal. So this is a very simple non-invasive tests like semen analysis, some blood tests for the ladies. We can do it anytime when they walk in there. But strictly give them about a year's time if they are younger to maintain the normal relationship and achieve a pregnancy. Failing which, we interfere.
Yes. Are there any signs or symptoms of female infertility?
The first important point is any woman who is having a regular menstrual cycle is more inclined towards normal ovulation, thereby a normal pregnancy can occur. If she has irregular menstruations in the form of a short cycles or a long cycle, scanty cycle or a heavy cycle, that shows that there is some disovulation where her chances of conception is going to be lower. Any woman who has got a dysmenorrhea, dyspareunia, any difficulties during their menstrual or the normal sexual intercourse definitely has got some pathology with which they had just going for that. So on the female side, we look for the regularity of the menses, and then on the male side, we ask them about the sexual practice, their erection, and their ejaculation. Everything is normal, then we take it for granted the signs and symptoms of infertility are not present with them.
And briefly, if you could enumerate that, what are the causes of infertility?
One third of the entire infertility, the male is at fault. One third of the entire infertility, the female is at fault. The remaining one third, both male and female are at fault. So, given an option, 50% the male is responsible, 50% female is responsible. On the male side, we have what we call it as a sperm production, sperm transportation, sperm delivery. So there are defects can be here. The count may be low, or there may be no count, or there may be a normal count. So these are all the probable reasons from that man we can just contribute to the male infertility. On the female side, it could be a vaginal infection, cervical erosion, uterine anomalies like fibroid, fallopian tube blocks, dysovulation, tuboperitoneal factors like pelvic inflammatory disease and endometriosis. These are all the probable causes in the female.
So, does lifestyle also affect fertility? If so, how?
It is very, very important. It is a first line. For example, you take a man, his lifestyle, he should not smoke, because smoking definitely affects sperm production. Alcohol, he has to slow down, because alcohol increases the desire but decreases the performance. So alcohol has to slow down. He has to be on a regular exercises, at least half an hour walking daily. And then he has to make a balanced diet. He should not eat junk foods and odd time foods. All this has to be avoided. If he is able to manage this lifestyle, obviously his BMI is going to be somewhere near 25. So that is going to lead into a normal life. For example, if he is going to violate this, if he is going to become obese, his erection is going to be a problem, his ejaculation is going to be a problem, there will be excess of estrogen, so thereby there may be a oligoasthenoteratospermia can come. So these are all the lifestyle modifications and lifestyle changes which can affect the male infertility. On the female side, if the BMI is not maintained properly, there is exogen aromatization takes place in the peripheral fat of the lady, thereby her ovulation is going to be altered. She is going to get a dysovulation. She's going to go in for a more like a polycystic ovarian syndrome, and then there is going to be a lot of issues about ovulation. Even if you have to just go through the what we call it as hello. Am I
Yes,
audible?
yes. Yes, sir.
Yeah.
Yes, sir.
So, yeah, even if it happens to be is something like, the if they are going in for a obesity related procedures, or even if they go in for an assisted reproductive technology, there again it is going to be a lot of issue. They will not respond like any other normal person. So that is to be considered before we treat the patient.
So now you did touch this topic, but now I want you to tell us in detail, how do you investigate infertility?
Fine. The very important thing is, as I've said, if they have come at the right time after spending 1 year or 1.5 years, you have to be aggressive. You cannot take months and months after treatment. You have to orient all your treatment within one, maximum 2 months. For example, if the woman comes in the mid cycle with her husband, I will ask the husband to do a semen analysis. Then I will ask for a serum progesterone on day 21. If the serum progesterone is abnormal, I will ask them to come on the second day with the TSH, prolactin, FSH, and LH in case if the age is advanced. And in the meantime, if the woman is less than 3 years marital life, younger than 25 years, I will subject them for hysterosalpingogram. So looking at this, I will do a tubal evaluation. I will do a ovulation studies. I will do a male infertility, male investigations. Everything I will be able to do it in about 1.5 to 2 months.
So how does keeping a track of basal body temperature helps? A viewer wants to know.
The It's a very very important question. Probably the best question I like on it, because I have been trained by Dr. B. N. Chakravarti in Calcutta. He has taught several things about basal body temperature chart. It's one of the simplest thing which we can do. Take a thermometer, put it under the tongue for about 2 minutes, and then record your temperature in the morning before you get up from the bed. Number one, there will be a first half is called follicular phase. Second 14 days is called luteal phase. First 14 days temperature will be less than that of the second temperature. Second half will be at least zero point 0.4 to zero point 0.6 will be more. What we call it as a biphasic chart. So if there is a biphasic chart, then that denotes ovulation. If it is a monophasic chart where there is no biphasic variation, it is only straight line, still it does not rule out ovulation. That is point number one. Then look at the temperature. If it is more than less than 97.6, what we call it as a low monophasic chart. And if it is low monophasic chart, the probable reasons are hypothyroidism, hyperprolactinemia, hypogonadotrophic hypogonadism, or premature ovarian failure. So, among these four, the premature ovarian failure and hypogonadotrophic hypogonadism are very rare. So, you commonly come across only a hypothyroidism and hyperprolactinemia. There again, on the 12th day, you put a speculum and look at the cervical mucus. If there is an abundant cervical mucus with a low monophasic chart, it is only a hypothyroidism. If there is no cervical mucus and then it is a the low monophasic chart, it is only a hyperprolactinemia. So you will be able to use this basal body temperature chart to study the ovulation pattern, to study the to diagnose anovulation, to also diagnose and other associated endocrines. And we can always teach the couple to plan the contact during the variation, and that is the mid cycle. There, it will also help them to motivate them to take part in the treatment of infertility.
So you told us what are the tests you would like to do on the first visit, so that an idea is there what to expect. But besides that, what are the other investigations that are done in females for infertility?
Female infertility, If it is for ovulation study, serum progesterone on day 21, FSH, LH, prolactin on the day 2. This is the utmost thing what we just try to do it. If we have a good ultrasound, when you do an ultrasound on the second day, we do what we call it as an antral follicular count,
Yes.
which will tell us about the ovarian reserve. So this is more than sufficient on the ovulatory factor. About the tubal factor, we have options to do either the hysterosalpingogram or laparoscopy. If the woman is younger than 25 years, married less than 3 years, and then there is no previous pelvic surgery, there is no signs and symptoms of endometriosis, I would prefer to do a hysterosalpingogram. If she is older woman, married for more than 3 years, presence of a previous pelvic surgery, or then there is a signs and symptoms of endometriosis, or if there is an adnexal masses, then I will plan for hysterolaparoscopy. The difference is hysterosalpingogram can be done as an outpatient. There will be a minimal pain, but we have to counsel that woman. For example, I always tell my patients this is an outpatient simple procedure. You might have a pain. The pain will be similar to that of the first day of your periods. Always you have been bearing the first day of the periods pain. The same way this is going to be there only for about 5 minutes. You tell them, they understand, they come forward, they get primed, and they cooperate, and then we do the case easily. And in case if there is a high risk patient, then we take them to the theater under anesthesia. We do both hysteroscopy and laparoscopy together in one sitting so that we get a complete information. On the female male side, we'll just go for a basic semen analysis. If the semen analysis is abnormal, then you look for certain specific hormones like uh, estradiol, testosterone to find out the ratio, whether they need any anti-estrogens. And then we can just go in for special sperm function test in case if they are going to be subjected to assisted reproductive technology.
Right. So, can ovulation be checked at home by the patient herself?
Very well, it can be done. Just like the pregnancy kit, the LH kits are available. So they on the 12th day they put 3 drops of urine and look for 2 stripes. If it is one, then it is negative. If there are 2 stripes are there, just like a pregnancy, that denotes LH is coming. So from the onset of the LH, it is about roughly 12 hours to 24 hours the ovulation is going to occur. So if they can have a normal sexual contact during that time, they can very well prime it. This is one of the simplest, easiest method with which earlier part of the couple, when they are married for 1 year, 1.5 years, when they are trying it out, they will be able to get a fruitful result.
Okay. Next thing that we want to know from you is, sir, that what lifestyle changes for the couple who are trying for pregnancy will help them in conceiving?
Yeah. First, they just take a detailed history about their habits. For example, men about smoking, the alcohol, and the eating time, habits, occupation, and then other various activities. We just take a detailed list thing. Look at his BMI. If the BMI is normal, you can just ask them for a small lifestyle modifications like walking, taking a fresh fruit every day. That is an antioxidant. That will scrotal cooling. Take a mug full of cold water, immerse the whole scrotum morning 5 minutes and evening 5 minutes, and that should be good enough. For a woman, from the vagina, if there is a vaginal infection, this that has to be very cleared. Instead of going through a routine testing and other thing, I strongly recommend them to take the domestic curd, which is nothing but lactic acid, to apply it on the vagina every day and have a wash after 5 or 10 minutes. So this will completely clear the vaginal part of the infection. And then look at the BMI. If the BMI is on the higher side, you put them on a good strict 1500 to 1800 calorie diet, high protein diet, muscle strengthening exercise, a good walking per day. So these are all the lifestyle changes we will recommend them.
A viewer has asked us that does a man have to refrain from using perfumes and deodorants?
Usually it is not so, and perfumes and deodorants does not kill the sperms in a normal way. However, when they are coming for infertility clinics like assisted reproductive clinics or for IUI, we ask them to refrain because they contaminate our lab. That is the reason. But by itself, that perfumes does not play a part in infertility.
Another query that we have is that most of the young couples nowadays are working on computers, they have cell phones. So, how to exactly use and how to avoid excessive use and where not to, keep them near your body parts. Is that helpful or no?
Now, the first is again, as I told you earlier, look into their BMI. If the BMI is out of control, then you have to take a stick and sit with them. You would just have to tell them
Hmm.
very clearly. They have to, whether even if they are on the walk, ask them to put a hands free, keep walking within the house, and then take the call. you know that is the way in which you just have to tell them. In case if they are sitting on a computer, ask them to put on a foot massage and just keep walking within the same place. No, something like that. We have to do some ballistic exercises has to be done, and they have to stick on to the diet. And then they should, the screen time is not in your hands. If it is, you have a young school going kid, the time is your hand. Whereas if it is an occupational, the time, screen time is not in your hand. So ask them to keep doing some kind of an exercise as they are working, and then probably that will be useful.
Burn your calories alongside physically,
That's right.
right?
That's right.
Okay. So now another person wants to know that does infertility always mean treatment with IVF, or we do have some other choices also?
The If you list the staircase of infertility treatment, first is monitoring of ovulation. Second is ovulation induction and monitoring. Third is controlled ovulation induction and IUI. Fourth is IVF. So, by normal sense, when the patient walks in with infertility, we try to help them. We look into all the other factors. When everything is normal, we call that as an unexplained infertility. In that scenario, we monitor the ovulation and ask them to have a contact. 2 months passes, nothing happens, you induce ovulation and then look for the follicular development and then try. 2 months passes, still nothing happens, then add a small dose of gonadotropin. Instead of one egg, aim for about some three eggs and then plan for an IUI. 3 or 4 cycles of IUI fails, and then probably we'll go in for IVF. The place where we directly go for IVF is severe male factor, oligoasthenospermia, 1 million count or a no count, where you have to take a biopsy, you go. And then if there's a very poor ovarian reserve, her antral follicular count is low, her anti-Mullerian hormone is very low, she's already taken about 1 dozen IUIs and failed and come back to us, then we ask them to go in for IVF. Normally, for IUI, first cycle will be 25%, second cycle will be 28%, third cycle will be 28%, fourth cycle is 11%. So that is, even if they normally try to have a contact, it is 20%. So it is going to be lower than that. So that is the reason after 3 cycles of IUI, in case if they do not progress, we subject them for IVF.
Right. So, this hysteroscopy and laparoscopy that you were talking of, at what stage would you generally like to do this? How many months into the treatment or after what all tests have been done?
Yeah, the baseline, as I mentioned, age of the patient. Older the age, I won't waste time. I'll just put them directly for the hysterolaparoscopy. Married for a long time, say 8 years married, they are 28 years, they come back to us, then I'll put them on thing it. Previous endometriosis, known case of endometriosis, operated, then I will subject them for laparoscopy. So in case if it is simple, less than 5 years and less than 25 years, married less than 3 years, I will subject them for alternative hysterosalpingogram. And whenever we do an ultrasound, we do a transvaginal ultrasound. A good transvaginal ultrasound of high resolution will always tell us something about the cavity, if there's any small polyps or something protruding. If they are there, then we subject them for hysteroscopy and then simultaneous removal of the polyps. And in case if there is going to be an endometriosis, we try not to do much about it and look at the ovarian reserve. If the ovarian reserve is already poor, we use couple of shots of DNRH analog and then take them for a IVF. If the AMH is quite good, we try to do some corrective surgery and then try to plan for about 3 months of treatment, failing which we take them for IVF.
Right. So, any take-home message for couples delaying pregnancy beyond 35 years of age?
Yeah, the
The
first important
females.
point is yes, female. So the first important point is they have to look into their ovarian reserve. How do they know what is their ovarian reserve? It is something like your bank balance before you spend the money. So how do you know what is your bank balance? One is on the age. Higher the age, lower the reserve. So beyond 35, you have to be very careful. Second is they do a antral follicular count on the second day. If the count is between 8 and 16, it is normal. When it is less than 5, you know that it is poor. Third is the anti-Mullerian hormone. Normal level is between 1.8 and 3.6. If it is less than 1.1, then you know that it is very poor. So if you have a good ovarian reserve, please go ahead, plan your dates. And if you think that your reserve is poor, either you go in for, if you are married, go in for a IVF, freeze the embryos, then when you plan, transfer the embryos. If you are not married, please go ahead, do ovarian stimulation, freeze the eggs, and then when you get married, try naturally. If it fails, you come back to the IVF center and then use these eggs. This is the take-home message I can give them.
Right. I was going to ask you this as the next question because you are president of the Fertility Preservation. And recently, an actress from Mumbai, she wrote about this in her Instagram that I preserved my eggs when I was 30-year old. And since then, many viewers have asked us, should we do it? So, at what age would you recommend that if she's not married or unable to have babies right now due to some commitments? So, at what age she should get her eggs preserved?
30 is the cutoff level. 35 is the upper limit. So between 30 and 35, you just see, look at the other factors also. For example, previous endometriosis operated, or she's a virgin woman without any surgery or anything, whether no partner available. In those issues, you can between 30 and 35. Beyond 35, going and then freezing an egg is a waste because you might have an abnormal oocytes because your ovarian reserve starts declining by about 35 years. Even though your hormones might show you up to 40, the reserve declines. Your incidence of congenital abnormalities increases, incidence of miscarriages increases after the age of 35. So a good ovum will be produced before 35. So that is the reason between 30 and 35, you can just freeze the eggs.
Thank you so much. You told us a lot today about small things that we don't usually get to know. And thank you, Dr. Gopinath, for joining us today. Could you show us the certificate, please? So, Dr. Gopinath, this is a small token of respect, and we
Thank
would
you.
like to have you again with us talking more about infertility and giving our viewers more knowledge about infertility. Thank you so much. That will be
Thank you
all
very
for
much.
today. Dr. KK Med Talks will return tomorrow at 7 p.m. with another edition of the show. Keep watching Dr. KK Med Talks. Namaskar.
Thank you.
Thank you.